So, good evening once again.
Good evening.
Yes, so welcome again to our AfroDX Clinic Unknown. Today, I'll be presenting a very intriguing case to Dr. Joseph. So, this is the real case scenario of the one of the patients whom I happened to attend in the ward. Yes, so I'll be presenting to Dr. Joseph. So, I'll be presenting today a 24 years old female who presented with excessive water intake for 1 week. Uh, Also excessive urination for 1 week.
Yeah, thank you very much. So I think I'm going to co-discuss with Roland a little bit of it, and it will be fun that way. Unless you guys think it is. What do you think? Yeah. So Roland, can you hear me?
Yes, Joseph. I can hear you. I can get you.
Anything comes to your mind when you see this chief complaint?
Um, the chief complaint of excessive water intake and excessive urination to a female who's 24 years old. A lot of things come into my mind, but the first thing which is actually very intriguing is actually this with this complaint. I am thinking of an endocrine origin being the cause of this presenting illness. Now, a lot of things come into my mind. Am I dealing with the patient who is actually presenting with either issues of endocrine related, either with some diabetes mellitus or diabetes insipidus, because they both present with excessive water intake and excessive urination. But what is intriguing to me at this young age, 24 years old, we know we come to understand that most of endocrine diseases, the risk factors, they are usually developed towards either early in life or late in life, and they are usually related to either diet issues and issues of insulin resistance or either insulin dysfunction. So, with 24 years old female with these complaints, first in my assumptions, I know that I might be dealing with endocrine issues, but autoimmune diseases which might present with these complaints or either malignancies or either infection, they are truly not in my list right now. So I think with just few things to begin with, I'm throwing up my mind to focus on endocrine origin.
Yeah, true. It's that's very true. And if you think of endocrine, that's the most common thing that we see. But as we say every day here, is that you should define the problem so that you can solve it properly. And I agree completely with you. So I believe the problem we are going to solve in a chief complaint like this is I've used to seeing patients like this is that this patient is urinating a lot. That's why he's taking a lot of water. So probably at the end of the day, we're going to solve a polyuria problem. And when we say polyuria, is SEBA will measure the amount of urine this patient produces in a day, and if that makes 3 liters, that will be polyuria. And I think we have had a discussion of polyuria here one day, and we said at the end of the day, you have only two arms, whether it's a solute diuresis or a water diuresis. That what you're seeing is either there is a lot of solute pulling in water coming out with it, or there is just a lot of water without the solutes. The endocrine problems that you're saying, true. Diabetes, for example, that's the solute diuresis, a lot of sugar pulling in water. But yes, you can have another endocrine problem, which is just a lot of water, and that's diabetes insipidus. Someone cannot reabsorb water proper, water goes out. But there are other problems. Think of urea, for example. It's a solute. And if you have patients who have been on ARCI, when they return back to their normal, they have polyuria because of the urea. And other things that we'll see, like if you give someone a lot of mannitol or 3% normal saline, they make a lot of urine. So yeah, we are in that line, and we will see at the end of the day which arm this falls into. So Seba, let's give us the HPI.
So the excessive water intake, so it was persistent, gradual onset, progressive. So it was accompanied by a constant intensive fasting. So the patient could drink up to 20 liters of water in 24 hours. Then the excessive urination was also persistent, gradual onset, progressive, reported more at night, and the patient reports to experience up to the recorded urine output up to 24 liters in 24 hours, with an average of 1 liter after every hour. So the urine was an extremely diluted urine, so there was no reported aggravating or relieving factor. So it was not associated with early morning severe headache, vision loss, convulsions, or loss of consciousness, excessive drying up of skin, hair loss, the period of deep sleep, confusion, neck pain, jaw pain, or any abnormal behaviors that were characterized by visual, auditory, or any tactile hallucinations. So there is no history of unintentional weight loss, excessive drenching night sweats. There was no cough, no chest pain, no shortness of breath or lower limb swelling. There is no history of previously had trauma, no reported history of previous brain or spine surgery. There is no history of drugs or substance intake, such as lithium or ethanol. So there are no skin rashes that were reported to the patient, any increased sensitivity to light, dry eyes or mucous membrane, no joint pain or swelling. There was no bleeding or abnormal discharge from the nose, gums, or skin. There was no history of fluid intolerance or anterior neck swelling. So in the review of other system, it was unremarkable.
Yeah. So yeah,
Oh, Seba, do you want me to keep moving the slides or do they discuss the HPI first?
Maybe Dr. Joseph, you can discuss the HPI.
okay. Yeah. So Laurent, Seba is starting to tell us a lot of things, and very, very important. So he's been focusing on stuff that involve the brain and the spinal cord and some medications. What does your mind go when you hear those things that we are saying in the HPI?
With the ruling in and the ruling out of several information that Dr. Seba is trying to share with us, is trying to eliminate possible issues. So, for example, issues such as psychiatry disorders like psychogenic polydipsias, issues of side effect of some medications. We know diuretics can cause these symptoms, and even intense exercise with over hydration. Somebody might present with these symptoms. But here, I am not seeing symptoms of water intoxication, which will include symptoms such as nausea, headache, confusion, seizures, and even coma. But this patient didn't present with such symptoms. Um, with these symptoms being said, I'm truly trying to relocate where the possible pathophysiology of the symptoms might be happening. Am I dealing with the patient who is having insulin insulin resistance? But with this age, 24 years old, yes, diabetes type 1 and type 2, it's it's very common for this juvenile age to present with type 1. Nevertheless, we have seen a trend that even type 2 can begin even at such a juvenile age, such as person even dating back to 18 years old, and issue of cutting corners or cutting a clear diagnosis that this is type 1 and this is type 2. Age has now been not considered as one of the factors which we might see to our patients. So there are several few things, Dr. Joseph, they are trying to come into my mind, but I'm not seeing if this patient is actually presenting with psychogenic polydipsia. So still my buckets are limited with the two things, which is of insipidus or mellitus. So if you would, I would like to still think of whatever that is happening to this patient. These are the things where I am trying to think. Why? Because for me to come into a clear consensus of what is happening to this patient, I have to think of what is the patient presenting with. Then what are the possible causes of whatever that my patient is trying to present? Because if this they are oh, thank you, Michael. Let me try to adjust my position. Yes, the last thing is, where might this disease be going? So I have to think into those three buckets that what is the disease that the patient is presenting with, where is it originating, and where will it go possibly if the patient is not well managed. So I'm trying to think into that angle. So Joseph, right now I think you can continue with the next part. I know you have a lot to add from whatever that I've said. So as things will keep on coming to my mind, I'll also keep sharing. Thank you.
Yeah, sure. That's nice. So, yeah. So as I have said in the introduction, that's two arms. It says that we're dealing with. Seba has told us 24 hours, 24 liters of urine in the day, way far above the 3 liters cutoff that defines polyuria, and so we're dealing with a polyuria problem. So it says a solute or water diuresis, and solute diuresis usually is clear from the history because you can tell me non-diabetic, so okay, maybe this patient is on uncontrolled diabetes, is not on medication, or just the thing as the glucose that will tell us the sugar is 31 or 24, and that's it. But we haven't here a history of other solutes that we know, like if this patient was in an aki, for example, and recovering, that's not, it didn't come in the history. This patient didn't receive mannitol, didn't receive anything that can say this a solid diuresis. And if she was diabetic, Seba would have told us the history of diabetes. It turns out it's not. So the most likely scenario we're dealing with here today might turn out to be we're dealing with a water diuresis. And so Seba, when trying to tell us history of head injury, vision, stuff that are involved with the brain, mostly we have two diagnoses when we talk about water diuresis, and this is primary polydipsia, which is a psychiatric illness, as Roland is talking about, and the other one is diabetes insipidus. And um, I can say, if you're talking about diabetes insipidus, you'll define it into central or peripheral. And Seba is telling us a history, trying to route some stuff that can be localizing to the brain because that is where central DI comes from. And the rest, I think, will come from the lab, I believe. So if there is a third or other diagnosis around, it will remind me. But I think when we talk about water diuresis, we did about mostly two diagnoses. Very important to tell us this patient is not on lithium. So lithium will cause also a peripheral DI. And yeah, so probably let's hear the rest part of history, and think if I can come up with the differentiation of these two if one of it is a psychogenic polydipsia or DI at the end. Yeah, Seba, back to you.
Yes, thank you, Dr. Joseph and Dr. Roland, for an excellent introduction. So, in the past medical history of our patient is she's primgravida. Now she's currently 19 weeks gestation age, and she's having twin pregnancies. So, in the family and social history, it was unremarkable.
Okay, maybe is there anything that Joseph and Roland you'd like to discuss before going to the general exam, or should we head to exam?
I think you should head to the exam.
To my side, no. But if Joseph has, then he can share because I'm still trying to rethink what is trying to happen to my patient here.
Yeah, I think we can go to the exam so that we can save time also.
So, in the general exam, our patient was fully conscious, febrile, not pale, not jaundiced, not dehydrated. There was no oral thrush, no aphthous ulcers, no angular stomatitis, and there was no any lower limb edema or purple peripheral lymph nodes. So vitals, there are no there are no other stigmatas of chronic liver disease or kidney disease. Vitals were normal, and also an RBG for this patient was also normal. It was about 5.6. So in the systemic exam, central nervous system exam was normal, respiratory system was normal, cardiovascular system was normal also, and musculoskeletal system was normal. Her abdomen had positive findings, which was she had a fundal height of about 20 centimeters, which was corresponding with a gestation age of 19 weeks. Also, fetal heart rates were present of about 130 beats per minute, and also multiple fetus were appreciated during Leopold maneuvers.
Okay. Thank you, Seba, for sharing with us the information. Can you go back to the previous slides, please, where we ended? Yes. To the history of pregnancy. Um, the GA of this patient who is 24 years old, with multiple pregnancies. I'm trying to think if it can add me variable information, and the only variable information which comes to me right now is as the uterus is expanding. Actually, one of the things which I am expecting to a patient is actually to have a compression of the bladder, and the compression of the bladder will actually, because in that the normal volume of urine which this patient used to fill the bladder, then later have the urge to go and urinate, actually it will be reduced. So with history of pregnancy at 19 weeks, I'm not actually surprised to think much of the polyuria. But what comes in my mind here is actually the increased thirst which this patient is having. And with some normal pregnancy, that's not normal to have at least a urine output of 24 liters. This is much very exaggerated. So I cannot blame pregnancy with the issue of urine because of the progression of the babies in the womb. But then again, I'm trying to think in here: is my patient now having gestational diabetes mellitus? I don't know the infos which I am going to get right now, but if I can be patient and wait to the information which Seba will share in the investigation being done as a glycated hemoglobin or fasting blood glucose, it can really paint me a picture if the client William which I'm dealing with here is actually having gestational diabetes. But I'm also coming to what is really happening to my patient here is it's very rare to have diabetes insipidus in pregnancy. But however, the chances might be there. Being rare doesn't mean that it doesn't occur. The thing is that it occurs, but not as expected with the general population. So causes of diabetes insipidus during pregnancy, it can be caused by either placental overproduction of vasopressin, or this production of vasopressin, it can lead to decreased ADH action and also leading to inability to concentrate the urine, which then it will be seen as polyuria. So these are the things which currently I'm trying to think just on the past medical history. But if you can go to the examination there, can we go? Yes, the picture which I am seeing here to this patient who is fully conscious, not febrile, and all the general exam is looking normal, you see. But coming to the vital signs, I'm very much concerned with the BMI, which it happens to be normal, because if we could have found this patient having a BMI of above 25, then I could be thinking, okay, is this patient obese? Because with obese comes a lot of NCDs, and one among the NCDs which I'm trying to think to this patient is actually diabetes mellitus. But with the BMI and all the vitals being correct here, I'm truly still limited to point out a specific NCD, which is diabetes mellitus or insipidus, to be the culprit of the manifestations the patient is trying to manifest. Then coming again into the next slide, Seba, if you can. Yes, here I am seeing everything from the central nervous system is normal. So I am actually out of knowledge of whatever that to share at this point. Then I'm passing the mic to Dr. Joseph to help me to continue with the case. Thank you.
Yeah, thank you very much, Roland. I don't think I have much to say, but one thing maybe I think the exam says patient is not that much sick. And you know, if you have a polyuria of this much and you have diabetes, for example, you'll be very sick. So I'll put that on the down below my list, and yeah, but the rest is okay. And I think we should see other history. I think the labs now. So,
Thank you, Dr. Roland and Dr. Joseph. So moving on to the part of investigations. So the CBC had normal parameters. In terms of the other metabolic panel, the renal function test and the liver function test also had normal parameters. Serology were all negatives. Thyroid profile was normal to this patient. The ANA was done, which was negative to these patients. So some of the hormones were done. So luteinizing hormone was done, the follicle stimulating hormone, and prolactin hormones were done, which were found to be normal range, concurrent with a pregnancy condition. So serum osmolality was estimated, and it was found to be around 463 milliosmoles per kg. So urinalysis was done, and the urine specific gravity was 1.001, although urine osmolality was not done, and ADH levels were not done. So brain MRI was done, which had normal findings to this patient.
yeah, can you take us back to the labs? So, Roland, the case ends up here. And what do you think? So, first of all, Seb, I think my normal serum osm is 275 to 295. This is elevated, eh?
Yes, this is elevated, yes.
And the urine, the specific gravity of the of the urine is usually 1.010 to 1.030. So this is also low.
Yes, this is low
Yeah,
urine specific gravity.
sure.
Yes.
I usually memorize this 1010 to 1030. So 1.010 to 1.030. So yes, Roland, the most important labs here is the serum osms and the urine specific gravity. It's unfortunate we don't have the urine osmolarity, but I think we can proceed with this. What do you think with these labs?
With these labs, Dr. Joseph, I am trying to think the main causes of increased serum osmolarity, and maybe I might have a loop of several things which they are pointing down to that possibility. So number one will be actually dehydration, and this will be because of loss of water. Either can be due to vomiting, diarrhea, sweating, or burns. So to this patient, the history of passing urine, at least which actually was presented as the main complaint, I am not surprised of that to find the serum osmolarity being high. But this paints a picture that I'm having higher concentrates of the solids. But also hypernatremia can cause me have increased serum osmolarity, and this is due to high blood sodium, um, which will be actually when a patient loses water, but is having actually preserved sodium levels are actually intact. But another thing which can cause estimated serum osmolarity will be hyperglycemia. So a patient who has high blood sugar pulls out a lot of water out of the cells um, into the blood, which will actually paint a picture of increased osmolarities. But also the same to diabetes insipidus will actually cause elevated serum osmolarity. And the reason will be actually due to loss of water through kidneys without solute being lost. Other things which I truly believe that it was very, very important also, if Seba is going to share with us later, is actually the serum glucose of this patient, either fasting or by glycated hemoglobin. It can point us to a very, very, very good picture. But also the ADH levels were not done, which would actually would have helped me to find the real cause of polyuria and polydipsia to this patient. MRI being done, a lot of CNS or CNS malfunctions, they are actually being ruled out. So Dr. Joseph, right now, still I am trying to put on the top of the culprits of this patient is actually diabetes, mellitus as number one, and the second thing is diabetes insipidus. But I'm having a limitation of some few investigations, which I truly believe they're later going to be shared, that we might have a different picture in here. Thank you.
Yes. So fasting blood glucose was done to this patient, and patient had consistently normal levels of fasting blood sugar levels.
Yeah,
Okay,
and
okay,
Yes,
thank you.
also electrolytes were done, and most important, the sodium levels were also within normal limits to this patient.
sure. Yeah, Roland, I agree with you. So, because we have time, let's discuss between me and you and see where we end up. So, I told you, say that we have solid diuresis or water diuresis. You know, the urine specific gravity, it measures how concentrated the urine is, right, Roland?
Yes, very true, Joseph.
And this is low, which means it's too dilute, right? So, Roland,
Sure.
if you think if this was a solid diuresis, would the unit specific gravity be high or low?
Um, this could actually be low.
Think of someone with a lot of glucose in the urine. The specific gravity of the urine should be high or low?
The specific gravity for a patient with a lot of glucose will actually be high
Yes,
due to glucose
true.
makes urine being concentrated
Very true.
actually.
Very true. So that's just an example. But if also other solutes, if they were there, they would take this specific depth of of the urine high. So probably just having this specific depth of the urine, we can say this is can not be the solid diuresis, and we are dealing with the water diuresis here. And if there is a third diagnosis, Seba will tell me. But I think I will end up, if I believe this patient has water diuresis, diabetes insipidus, primary polydipsia. So let's start with primary polydipsia. Primary polydipsia, these guys have a psychological problem. They drink a lot of water. They just drink a lot of water. That's it. So Roland, what do you think? If you drink a lot of water and your urine will be too dilute, so this urine specific gravity is in keeping with that, right?
Sure,
But
sure.
how about what do you think if you drink a lot of water? How about your serum osm? How should it be?
My serum O's actually will be low because
Yes,
due to will be very very low.
yes, because everything is working well except you are drinking a lot of
Yeah,
water. So your body is responding, it reabsorbs that water. Your serum osm
sure.
goes low. How about your sodium?
My sodium goes low too because
Yes,
it's wherever water wherever sodium goes, also water follows. So also sodium, I expect it to be very low if
exactly.
everything is working.
Exactly. I agree with you. So with this just these labs, even if we don't have the urinosin because of limitations around here in the place that we live, but still we can arrive at the diagnosis probably by seeing this patient as urinosin, I mean serum osim this high. It means she is drinking a lot of water, but what happens? She cannot reabsorb the water. It goes out. She pees out the water. So Roland, what is that?
That's in speeders
Yes,
actually.
exactly. So this is, I believe, turns out to be insipidus. So Seba is telling us, why is he telling us about the MRI?
The essence of MRI here, I think he's trying to look if there might be anything which is causing. I'm not really trying to get something here, but I'm truly thinking maybe there might be CNS malfunctions,
Yeah.
which might lead to the presentation of the patient. But I can't still point out exactly clear which one.
Mm,
You can help me on that,
sure.
Joseph.
So it means ADH has to be made from somewhere, right?
Sure.
The pituitary, is it posterior or anterior? I think it's posterior, right?
Yes,
It's
posterior.
posterior. It has to make the ADH, and it goes and acts on the kidneys. That's the issue. So if somebody is telling us the pituitary of this patient is normal, it tells us this is more likely to be peripheral DI and not central. And if we sit at that peripheral DI, you have any clues? He has told us, Seba, in the history, patient is not on lithium. I have read some cases of lithium causing peripheral DI. But do you have any other clues to that? Because you're a resident, I think you have to know those causes more than me. I'm joking, by the way.
No, no, no. Actually, no.
You don't. Yeah. So I believe there is uh, a genetic disorder uh, that causes peripheral DI. Um, Hypercalcemia causes a peripheral DI, but we're told the electrolyte were normal, and we don't see anything else about hypercalcemia here. But if this is a genetic disorder, you think, why should it come at 24? And then my mind goes to pregnancy. I'm not sure in my in my understanding of peripheral DI, I'm not sure if pregnancy are there, but the first thing I will do in this patient is I will open whatever place that I read up to date or Google or ChatGPT and ask if there is a relationship between peripheral DI and pregnancy, and see. And if there is no, then I'll have to go and read more about the causes other than medications, hypercalcemia. Um, yeah, so that's where I am. And what do you think, Roland?
My thinking is still similar into line with you,
Mm,
and up to the point where
mm.
we are trying to gather points which they might actually lead us to differentiate what is happening to this patient, either it's diabetes mellitus or it's diabetes insipidus, and hyper with the osmolarity being high, and MRI actually pointing to no possible causes of issues of either trauma or tumors, and infiltrative infections, still doesn't rule out insipidus, and still the diabetes insipidus in pregnancy to this patient is top on the list compared to everything which we have discussed, I think.
Yeah, and I agree with you. So, Seba, I think we don't see anything else that maybe causes this nephrogenic diabetes insipidus that we're thinking, and no medication, no hypercalcemia, genetics is likely because at 24, why should it wait at 24? Uh, Probably it's the pregnancy. That's where we are, right, Roland?
Yes, that's where we are trying to think it's maybe because of the pregnancy, because on the etiologies, mostly they can be due to ADH dysfunction. So MRI would point to us if there is anything wrong in the hypothalamus. And next to that, which is actually listed in our list, is the possible causes due to pregnancy. And the patient whom we are discussing is happening to be pregnant. So maybe that's what we are seeing the picture of diabetes insipidus of nephrogenic cause due to actually pregnancy.
Yeah, Seba, teachers.
Thank you, Dr. Joseph and Dr. Roland. I think that was an excellent teamwork and excellent flow. I think you captured almost all the important details that were supposed to be kept in line in this case. So yes, our provisional diagnosis to this patient is diabetic insipidus, with a strong index that this could be a gestational diabetic insipidus, which has been termed as transient diabetic insipidus of pregnancy. So now, according to the latest literature, they discourage the use of the central diabetic insipidus together with the peripheral nephrogenic diabetic insipidus. So that some of the newer terminologies which have been listed primarily to be used now. So for the central, the correct terminology now, which is recommended, is arginine vasopressin deficiency. And for the nephrogenic, the terminology that has been kept forward is arginine vasopressin resistance. So just some few learning points. I think most of the points that have been strongly highlighted by the presenters. So as Dr. Joseph said, primarily just at the beginning of our case, we are dealing with the suspected polyuria. So always when you're having producing urine which is more than 3 liters in 24 hours, or if you put it in terms of mils per kg, anything above 50 mils per kg, then suffices the criteria of being termed as polyuria. So the most important thing to measure, first and foremost thing is what is the glycemic level of that patient, the sugar levels. Then electrolytes, very important, is sodium levels, followed by potassium levels. So as correctly said, potassium is also, hypokalemia is one of the strong risk factors which can predispose individual into developing the nephrogenic diabetes insipidus, together with plasma and urine osmolarity. So a major challenge which can be faced sometimes is that plasma and urine osmolarity, sometimes they are not readily available in most of the centers, but there is a way in which you can calculate, for example, plasma osmolarity. You can estimate by using a formula. So there is a formula which uses 2 times sodium plus the glucose levels in mmol per liter plus the BUN in millimoles per liter. Then from there, you can be able to estimate the plasma osmolarity. Urine osmolarity is also not readily available, but there is a very strong correlation between urine osmolarity together with the urine specific gravity. So almost all the information that you can be able, which can be obtained from urine osmolarity, if it's not available, then the urine specific gravity, which can be obtained just from a simple urine dipstick, should be used as an alternative. For example, in our case, we didn't do urine osmolarity. We were able to do the urine dipstick. So we got the urine specific gravity and also plasma levels from the formula that I said previously. So similar approach as Dr. David said. So the most important thing is to know that are we dealing with a solid diuresis or a water diuresis? So in most of the time, if it's a solid diuresis, then the patients will be having a very high urine osmolarity. That means the specific gravity will be significantly elevated. For example, in patients with diabetes mellitus or patients with diuretics intoxication, for example, mannitol or 3% sodium chloride. Now, in our case, our patient had a lower urine-specific gravity, which is consistent with low urine osmolarity. So in this case, there are 3 major things. So the first thing is primal polydipsia, which is usually associated with some psychiatric condition. Patients tend to drink water nonstop. So in most of the times, primal polydipsia is associated with very low plasma osmolarity, which was not the case in our setting. So in our setting, patient had a high plasma osmolarity. And also in patients with primal polydipsia, it's usually associated with high extent of dilution. So they present with dilution or hyponatremia. Then in our case now, we had elevated plasma osmolarity. Urine osmolarity, which was correlated with urine specific gravity, was elevated. And this now gives us to the points of possible diabetes insipidus. So there is a way in which you can be able to differentiate primary polydipsia and diabetic insipidus. So there is a test which is known as a water deprivation test. But our patient was pregnant, so water deprivation test is strongly contraindicated in pregnancy due to an increased risk of uterine placental insufficiency and posing more risk to the patient and the fetus. So usually it's not done in pregnancy, and it's supposed to be deferred until, if necessary, until to the time of postpartum. So moving ahead, this is just I hope you can be able to see this. So it's trying to look to, what could be the most common causes of the central diabetes insipidus. So commonly in relation to pregnancy, what has been commonly reported is what is known as the Sheehan syndrome. So patients is usually, they get, if they had a significant postpartum hemorrhage, they tend to develop a pituitary gland, which is necrosis of the pituitary gland, which is postpartum, a syndrome which is known as Sheehan syndrome. So they tend to present with a central diabetic insipidus together with a low levels of almost all the hormones that are produced in the pituitary. So there are some of the things which can also have been reported also. Presence of history of trauma, specifically trauma involving the Sella-Tusica area, or patients who are also having any tumors. So tumors in the pituitary, so the pituitary macroadenomas and microadenomas have also been strongly reported to be associated with central diabetic insipidus. So there are some of the granulomatous diseases also have been reported to be possible causes of central diabetes insipidus. Rarely, central diabetes insipidus may be associated with the post-infectious autoimmune diseases such as the Guillain-Barré syndrome. So in terms of the nephrogenic diabetic insipidus, which is there are some of the causes. So commonly we have acquired tubular diseases. So for example, when you get infection, then the collecting ducts, that is the ADH receptors, become insensitive to the vasopressin hormone. So patients who are having also analgesic nephropathy, patients with infiltrating diseases, commonly multiple myeloma and amyloidosis and sarcoidosis. Electrolyte imbalance, I mentioned hypokalemia, also hypercalcemia has been listed, together with also patients who present with sickle cell anemia. So they tend to have significantly papillary necrosis, leading into impairments of the ADH receptors functionality, making them to be very insensitive to the vasopressin. So as correctly cited by the two presenters, drugs are also very common. Lithium has been heavily mentioned as one of the most common causes of nephrogenic diabetic insipidus. So there is also ethanol has been mentioned together with amphotericin B, specifically the conventional amphotericin B. So there are some of the other renal pathologies such as polycystic kidney disease and medullary cystic disease have also been reported to be associated with cases of nephrogenic diabetes insipidus. So just moving ahead. So today, just a quick review on what is known as the diabetic insipidus in pregnancy. So this is usually caused due to the transient deficiency of ADH during pregnancy or postpartum period. So this can occur for two major reasons. So the first reason is increase in placental vasopressinase production, which is commonly seen in multiple pregnancies. So if we have just a quick link, our patient was a primigravida, had multiple pregnancies. So one of the postulated theory, which can explain why our patient had diabetic insipidus, it could be due to an increased extent of production of the placenta vasopressinase, which usually degrades down the vasopressin, so leading into a total deficiency of vasopressin. So there is another postulated mechanism, which is decreased hepatic degradation of placenta vasopressinase. This is usually commonly in patients who present with preeclampsia with severe features that usually end up developing the so-called HELP syndrome. So there is an impaired functionality of the liver, leading into impaired degradation of the vasopressinase. So vasopressinase goes ahead and breaks down all the vasopressin, such that the pregnant woman won't be having such. So this has been so between the 8-week gestation to mid-pregnancy, the metabolic clearance of AVP increases 4 to 6-fold due to the increase of vasopressinase, but usually it peaks in the third trimester. So diabetic insipidus in pregnancy has been consistently mentioned during the third trimester, whereby you have the maximum functionality of the placenta and there is the peak production of the vasopressinase. But there are some of the literatures also report some few cases to occur during the first trimester and in the second trimester. For example, in our patient who was in 19 gestation age. So this is just a quick picture to show what happens. So we usually know that the vasopressin is usually produced by the paraventricular cells of the posterior pituitary gland. So pregnancy produces what is known as vasopressinase. So vasopressinase breaks down the vasopressin, leading into complete deficiency of vasopressin, which may lead into what is known as the nephrogenic diabetes insipidus, which is now known as arginine vasopressinase deficient. So This leads into decrease of the free water reabsorption and increase of the extent at which water is lost. So this is just the same picture which shows what happens. Same pathophysiology, increase of the extent of vasopressiness, more breakdown of the ADH. So there is a decrease of the ADH leading into more water diuresis due to impaired water reabsorption. So in terms of management, which can also act sometimes to help you in diagnosis. So there is a role of desmopressin empiric trial. So desmopressin is a selective agonist of the V2 receptor, which is found in the renal collecting duct. So it usually mimics the actions of the endogenous antidiuretic hormone. So of importance is that desmopressin is usually resistant to the degradation of the vasopressinase. So the vasopressinase enzyme has no activity against the desmopressin. So if you give desmopressin to these patients and they get a significant improvement, for example, in our patient, we gave our patient a desmopressin trial. We started with a low dose of 0.0 milligram TDS, and then we upgraded up to a dose of 0.1 milligram TDS. So there was significant improvement from the excessive urination of about 24 liters in 24 hours up to only about 3 liters in 24 hours. And even the water intake, which was initially about 20 liters, just after 2 days, 48 hours of desmopressin, the intake dropped down from 20 liters to only to about 2.5 to 3 liters in 24 hours. So if there is a significant improvement with desmopressin trial, there is a high possibility that what we were dealing with could be a transient arginine vasopressinase deficiency of pregnancy, or could be a possibility of pre-existing arginine vasopressin deficiency, which was existing prior to pregnancy. But in our patients prior to pregnancy had no any symptoms of excessive urination or excessive urinary intake, which makes high on the list to be a possibility of transient arginine vasopressin deficiency of pregnancy. And if there is a complete lack of response after you have administered desmopressin, then there is a high possibility of presence of pre-existing arginine vasopressin resistance. So adequate hydration is recommended. So we are telling this patient to drink to thirst, that to maintain continuous hydration and continuous access to water so as to prevent dehydration to this patient. So also low dietary sodium and low protein diets have been shown to be beneficial to these patients. So role of water deprivation test. I've said this is usually very important to differentiate between arginine vasopressin deficiency vis-a-vis primary polydipsia, but it's usually not done in pregnancy. And also hyponatremia usually is a common complications in these patients, especially in patients who do not have enough water or they have impaired thirst mechanism. So for patients with intact thirst mechanism with no water restriction, present with normal sodium levels, for example, in our patient. So our patient had an intact thirst mechanism and was able to drink to thirst and had freely access to water with no any restriction, which made her to have consistently normal sodium levels. But for patients with impaired thirst and patients who do not have free access to water, usually they may present with hyponatremia, which may present with other complications. So effective treatment is usually with desmopressin. So the starting dose is about 0.05 milligram 8 hourly. Then you can go up to a maximum dose of 0.2 milligram 8 hourly. So for our patients, we are able to attain at least normal levels of urine in a dose of 0.1 milligram 8 hourly. So desmopressin has been shown to have no any adverse maternal or fetal effects. So it's a drug that is safe in pregnancy. So usually these conditions may persist until immediate postpartum.
Yeah. Thank you very much, Seba. As usual, I've learned a ton from you. I didn't know if pregnancy can cause all this. And then, 3 years out of residence, I don't even know that they've changed the name. So nowadays you use AVP deficiency, AVP resistance. That's very good. So that's why we do this, because, things change and you come here, you keep learning. And so the teaching points were very good. And yes, Roland, that was a very good job, well done. We had Michael discussing here, we saw very nice. And today you're discussing, you didn't even know that you are going to discuss, and then just showed up and discussed, and you did very well. So we encourage others, if you think you want to discuss, just let us know. It's just easy like this. And as Roland is showed today. And yeah, so I can say, this, what we're doing here is the drilling, the training. One day you will see this case. For example, for to me, I've seen one case when I was a resident. There was no diagnosis at the end. Patient died, by the way, but I learned from that case. And then one day here, David presented a case to me of from human DX, and this is the third day now I'm discussing. It seems a bit easier. So if I see a case, to be on my fingertips, and probably Ryan, if one day he sees a polyuria case, to be also easy for him. So that's the main reason that we are doing this. Roland, any reflections from you, my friend?
Yes, thank you, Dr. Joseph. Thank you, Dr. Seba, for making me being a discussant today. From being a faithful attendant of AfroDX presentations, and today being a discussant, I've truly my confidence index has grown up. I've broke that I've actually broke that fear from being just a commenter in a box, but actually being a real discussant. It has really changed my perception, and my confidence index has actually increased. Um, as Dr. Joseph has actually pointed out, medicine is a never endless field of learning. If I was to be an attendant to this patient, let's say with a GP mindset, right away, a minute when I could have known this patient is just pregnant, I would drive into the hand of a gynecologist and obstetrician. But it has actually brought out a point to me that as a resident internist in training, I am I am actually part of a very big pivot onto handling a lot of cases. A good internist is the one who is able to actually coming to a concise diagnosis, but also knowing how to manage the patient, whether himself or linking him to a right partner. So with this case, I've learned a lot. Thank you, Joseph. It was a very good surprise, and I truly believe that in the near future I'll be able also to discuss again and again. And I'm following the good footprints of Seba
Yeah.
and Michael, whom were actually the first residents in AfroDX to be held as discussant.
Mm.
Thank you so much. But I hope on the next coming weeks, the next coming Sundays of May, I will communicate with Dr. David. I might have a case to present, and I truly believe that we are going to learn out of it. Thank you so much, Joseph.
Yeah, we'll be very thankful to have a case from you. Yeah, thank you. So, anything else from you, Seba or David?
Today has been a very good day, and thank you, Joseph, for taking Roland on board, and thank you, Roland, for being willing to discuss. And you did a great job. That was a hell of a job. So we look forward to many more showing up and discussing cases. It's been a few weeks now. I'm not discussing cases. I'm actually very happy because I get to learn from other people. You know, when you are talking, you do not hear yourself. I'm not sure if you know what I mean by that. Of course, you think out loud and you improve on your thinking, but I think also hearing from other people, you get to learn a lot. So today the house was packed. I'm not sure if Joseph, you are following the numbers. We've never had numbers like these.
Yeah.
So it's been a surprise, and maybe I should just ask Good Luck because I saw Good Luck is here. Uh, uh, how did you get hold of the link? I'm not sure if he's still
Okay.
around. Yes.
Yes, I'm around. Good evening, everyone.
Evening, good.
My name's Goodluck Leonard Misonge. I am the Sierra for subgroup D. We are MD5. We're just joining internal medicine. So we were lucky today. We were contacted by Dr. Kalani so that we can join this good presentation and learn how internal medicine runs out cases and also learn from our seniors. So it was a very good opportunity for us. We have learned a lot, and we think you'll be here for the coming presentations.
Well, thank you very much, and it's good to see you. Thank you, Gilemanus, for sharing the link. At first, actually, some members have left, but the peak was more than 75, I think. So we had many attendants today. So we'll keep sharing the links with you. Feel free to join, and maybe share the links because in the past we haven't shared the links with MD5s, but feel free to share with the CRs from other groups, and if they have the time and if they are willing, they can also join because we all we want to do is democratize medicine and clinical reasoning, so everyone is welcome to listen and learn and teach. So thank you very much, everyone. Once again, thank you very much, Seba, for preparing the case and for the good teaching points. So when Seba teaches, we learn a lot. So thank you very much, Seba. Thank you, Joseph and Roland, for discussing. I'm not sure if there's anything else from your side.
No.
Okay, so if there's nothing else, good night, everyone. We'll see you next weekend.
Night.
Thank you.